As you can see here, the Hex-Lock contour abutment looks very similar to a custom abutment. You'll note that the collar has a variable height. The lingual portion will be higher. The facial portion will be lower. And interdentally, you have a normal chamfer shape. This allows support of the papilla. It also provides for a highly cosmetic result by minimizing the facial margin. The contours and also the built-in flare provide for an ideal emergence profile. The contour abutment comes in a variety of flares and a variety of collar heights. The Hex-Lock contour abutment gently seats into the implant and is tightened down with a 0.5 millimeter screwdriver. This can be done immediately, or it can be done in a more traditional delayed fashion. Perhaps the greatest advantage of using the Hex-Lock contour abutment is the development of a very easy-to-use impression coping analog system. This comes as a prefabricated kit, and inside this kit you'll notice we have an analog, 2 copings, and a snap cap impression post. The snap cap impression post fits easily over the top of the abutment, and a traditional crown and bridge impression can then be made. The snap cap then will release from the abutment. A laboratory analog can then be placed inside, and this can be used to fabricate the model by your lab technician. Also delivered with this kit is a white waxing coping that the laboratory technician can use to fabricate the final crown. A temporary coping is also given with the kit and can be used to fabricate an immediate provisional. You know, there are quite a few advantages to doing a minimally invasive surgical technique. First of all, for the patient, you have significantly decreased swelling and significantly decreased postoperative pain. In addition to it, when we get ready to temporize these cases, there's much less bleeding, the field is drier, more secure, and we get a better immediate aesthetic result. The disadvantages of this technique are that you don't have the same amount of visualization as you would if you elevated a full thickness mucoperiosteal flap. Now, the research is a little equivocal about this, but some people believe and have found in their studies that you have decreased crestal bone loss if you don't elevate a flap. So what do we look for when we're determining whether a patient's a good candidate for a non-invasive technique? I'll show you right now. The first thing we want to examine on this patient is our overall buccal palatal width. And you can see here we have more than 9 millimeters of bone width. If we look at our intercoronal distance, we're also at about 7.5 millimeters. So we have good space in this area to use a non-invasive technique. The other thing we want to check out is the amount of keratinized tissue we have. Our mucogingival junction is right here. So in the course of making our osteotomy, we're not going to be eroding this tissue such that we don't have a good amount of attached gingiva on the buccal aspect of the implant. To determine the depth of our osteotomy, the pilot drill is etched, and the etchings are as follows: 8 millimeters, 10 millimeters, 11.5 millimeters, 13 millimeters, and 16 millimeters. As we mentioned previously, we're planning on placing a 13 millimeter implant in this area. Now remember, we have approximately 3 millimeters of gingival tissue on the crest, which means as we drill, we'll be drilling to this final line right here. The level of the bone will reach this line right here, which is 13 millimeters. This site has been grafted with Puro's mineralized cancellous bone about 4 months ago, and we really have good resistance to our drill. At this point in time, I like to use a guide pin to confirm that our angulation is perpendicular to the crestal ridge. It's also good to use the guide pin to determine our occlusal position. So for this, we remove the bite block. Open, please. And have the patient close down gently. Notice the wider portion of the guide pin is in place. And to depth. Open, please. And gently close. Relax your jaw and close. And we're in a more ideal position now. We can also see that our osteotomy is nicely in the center of our crest, equidistance between the adjacent teeth. We'll be using a 3.7 millimeter by 13 millimeter Zimmer one-piece implant. It comes packaged like the standard tapered screw vent implant and has an internal driver. The flat side of the driver corresponds with the most labial portion of the contoured portion of the implant. It snaps into place and is easily removed from the packaging. A little bit more saline, please. On the implant. There we go. Great. Each rotation of the Zimmer one-piece implant will seat the implant 1.2 millimeters apically. This allows you to carefully control the position of your margin. Now that we have the implant completely seated, we can double check our facial margin. We follow the margin down along the facial, and you see we have approximately 2.5 to 2 millimeters of gingiva covering our margin, which will give us an ideal cosmetic result. Also note, we're almost exactly equidistant between the two teeth. This is a regular body polyvinyl siloxane impression material. And it's here principally to identify the gingival margin. Open just a little, my dear. Open just a little more. Close down just a little. Great. Open just a little. We've let our impression set. Let's see what we end up with. Just relax, my dear. It's going to tug just for a second. Here is the result of our impression. We have good gingival architecture, and you can note that our snap cap is locked firmly in place. This is convenient because we don't have to worry about getting an impression of the margin, which is nicely subgingival. Included in the kit is a laboratory analog, which can be placed into the snap cap. This model will then be poured up by the laboratory technician and the final crown manufactured. Also included in the kit are 2 copings. The buff-colored one we will use to manufacture our temporary. The white-colored one is our burnout coping, which will go to the lab along with the impression and the analog for fabrication of the final crown. Preformed ion crowns are ideal for making chairside temporaries. The first step is to find the ion crown that's best going to fit in the patient's mouth. With our provisional coping in place, we're going to simply try in the ion crown over the top, placing it right directly over the coping and pushing gently. And it looks like that will work nicely as a chairside temporary. This then is passed over the top and held in place, and we'll cure it with a curing light. This then will capture the position of our coping. Here we see the ion crown. We've captured our coping. I'm going to simply place that coping onto our analog and add just a little bit more of flowable composite around there. Then I can trim this at chairside, reduce the occlusion, cement it in the patient, and she'll leave with a tooth. So here we have our analog that comes with a kit, and you can note that we've nicely adapted our gingival margin, and we've reduced the occlusal slightly. Let's see how it fits inside the mouth. So we'll slide our temporary in now. Cotton roll, please. Close down, honey. There we go, nice and hard. Open. And we have a little bit of tissue rebound, but we'll check our occlusion. Tap, tap, tap. Grind around left and right. Open. Good. So you can see we're still hitting just a little bit heavy. I'm going to reduce our occlusion down and we should be ready to cement. So we've adjusted our occlusion, we've adapted our margins to the temporary. Now we just need to cement it and do a final occlusal adjustment. Our final step is to remove the excess cement from our margins and confirm our occlusion. Hold the tooth down. Slowly close. Good. Close again. Open. So we've used the initial pilot, the 2.3 millimeter pilot, checked our positioning, and we're confirming our positioning now after drilling the 2.8 millimeter pilot. Close. Excellent. Close. Open. Close. All the way. Good. Open. Okay. So we've just placed a 3.7 by 11.5 millimeter tapered screw vent implant. You'll note on the fixture mount there is a flat side which corresponds to the flat side of the internal hex. It's important to have it oriented in this direction as the Hex-Lock contour abutments are designed for the lowest portion of the facial to align itself with this flat portion of the internal hex. Occasionally you may need to drive the implant slightly deeper. Conveniently, the same driver that attaches to the fixture mount also fits into the internal hex. So here we have approximately 3 millimeters of gingiva coronal to the end of our implant. So here we have the corresponding Hex-Lock abutment. This particular abutment that I selected has a cuff height of 1 millimeter on the facial and a flare to 4.5 millimeters, which should give us an ideal emergence profile for our final crown. Note, because of the well-defined shoulder and chamfer, the general dentist will not have to prep this abutment prior to fabrication of the final crown. Open. Thank you. Okay. Mirror. Close. Open. Close. So you can see we have adequate interocclusal distance for fabricating a provisional. So now we'll go ahead and take our final impression to send to the lab for fabrication of a crown at a later time. We begin our impression by placing the contour cap. The buff color indicates that it is a 4.5 millimeter flared impression cap. Good. Here's our impression, and you can see we've securely captured the relationship of the implant with our comfort snap cap. And then you can see we have perfect adaptation of the gingival margins. This will make it ideal for the lab technician to manufacture an aesthetic final crown. The Hex-Lock contour abutment is designed such that a provisional coping can go over the top. And on top of this we can place an ion crown relined for gingival adaptation. So we have the contour coping already on the abutment. We're going to add a little bit of flowable composite to the inside of our ion crown. And cure it. We'll fill in just a little bit more with our flowable and then be ready to cement. All right, now that we have our margins adapted, I'm going to take this to the lab, adjust the occlusion a little bit, and we'll be right back to cement. We've done our final little occlusal adjustment. We're now going to cement the crown with temporary cement. Close down, please. Nice and hard. Open. Close. There, just like that, and hold it for me. Excellent. So we'll do a final little adjustment on the occlusion. Heavy occlusion on the premolar tooth and the molar, and just a slight bit of occlusion on this marginal ridge, but nothing that's going to disturb this implant.